Can we go to the second presentation so that we can catch up with question time? The second presenter is Samuel Likindikoki. He's my mentee, so I'm proud to have brought in a male into the gender-based violence agenda in Tanzania. He's the lecturer and my head of department, which is also something really good. And he's a researcher focusing on areas of HIV intervention, intersections between HIV and AIDS and mental health. Some of the topical areas he's interested in include but are not limited to HIV as it relates to gender-based violence, mental health, and concurrent partnerships. Key populations, such as people who inject drugs, men who have sex with men, and female sex workers. I hope you'll tell us a little bit of the integration that they're working on. He has a number of collaborative research that he is working with Johns Hopkins School of Public Health and has been working with London School of Hygiene and Tropical Medicine. I'm really bad. I'm skipping all the good stuff. And currently working with the Medical Research Council of South Africa. Dr. Likindikoki works with the MUHAS-based Tanzania AIDS Prevention Program as the lead for the Gender-Based Violence and Alcohol Intervention Program. He also spearheaded the integration of GBV and alcohol intervention among people attending HIV testing and counseling services in Dar es Salaam City. May we welcome Dr. Likindikoki for his presentation.
Thank you so much. Just to make a bit clear that I work with MRC on a GBV prevention work with Anik is here. I don't want people to get the impression that I work from Cape Town. I work from Dar es Salaam. So Jesse and Charlotte, I've worked with them at the capacity of mentors. And it's really hard to speak up after Charlotte speaking. She made my work much easier in the next presentation, and I'll focus my talk on East Africa. I can talk here and there about some global data, but very much about East African research and intervention. I come from intervention, particularly clinical intervention. It's until very recent that I've been embarked on to look at the prevention aspect. So my inclination of talk will be a little bit biased on that. All right, so this is outline of my presentation. Next, please. Touch a little bit about background, of which most Professor Charlotte has talked about. And then I'll cite some of the interventions that have been done in East Africa. And I know there are so many of them that have been done, but I picked some few as an example to provoke some discussion in this meeting. And I'll touch a little bit about other evidence, particularly that has been done in East Africa, and a bit of summary. So it's going to be pretty short. So Charlotte talked more about, next slide please, about the interconnection between HIV and IPV. And I must say, at times, nomenclature, when you talk about GBV, you talk about IPV, you talk about VOW, they're kind of vast depending on which forum and which organization you're talking about. But by and large, we know IPV is a subset of GBV, and some of the research evidence talk about GBV and not talk about IPV per se. So we know about the HIV feminization phenomenon, of which we know most of who are affected by HIV are women. And when it comes down to young people, comparing men and female, the ratio is 3 for women and 1 to men. That's a big disconnect in terms of prevalence of HIV among younger population. Now, there's so many evidence that Charlotte talked about between interconnection and some odds ratio that kind of tell from different number of studies. I just cited one by Townsend, L, that was done in 2001, that talks about the risk, actually. It's kind of twofold, and depends on which study, then can be even more or less. And we know that IPV directly through biological mechanism or indirectly through the social constructs can increase the risk of HIV transmission. And as well articulated, they are all, they share probably common risk, and they are all health-related and deeply socially constructed. Next, please. So maybe I skipped that. This slide talks about the postulated and some evidence for biological evidence for interconnection between the IPV and HIV. And next slide. And the next slide talks about the social construct. That talks about the women vulnerability and the pooled risk that they share both between IPV and HIV. Next slide, please. So this is another version. We have so many versions of how do we see the interconnection between HIV and the IPV. But by and large, when you look at the barriers and contributing factors, and to what extent they bring a woman to experience of any form of violence, and then either through the forced sexual act that can predispose a woman to HIV, or through the fear or experience of GBV, that if somebody turns to be positive, then becomes a barrier for this person to get access to testing for HIV and also getting care that one deserves. And all these actually amount to either risk for transmission and to what extent it acts as a barrier for accessing services. So the next slide, please. So the next set of, next couple of discussion of slides, actually, I'll be talking about interventions and research. And I start with this one. This is a recent review by London School of Hygiene and MRC when they with DFID program that is currently underway to look at what really works when it comes to prevention. And earlier in the morning, there was a discussion about financing, empowering women financially, and to what extent that can pose as a risk for HIV. And so we know about the image study that was done in South Africa and is being replicated in Mwanza, Tanzania. And it showed really pretty good result of reduction of about 55% of violence when financial microfinance was coupled with gender transformative component. So it's not just about dishing out money, but you need to do something about addressing these vulnerabilities. So we have layers of what really has been shown by this recent review that to be effective, and those programs that are shown to be promising. And some of them, they've shown either conflicting or not effective at all. And I cited just few examples of those seems to be promising intervention, and that is parenting programs. And but things like advocacy for people to get access to services, the review shows that it's not really convincing, it's conflicting. And things like routine screening or access to criminal justice services have shown not to be really effective. So this is a question that, when I talk about the next couple of slides, we need to reflect, because when it comes to intervention, we have a number of organizations, we have government responding, either by giving services or by doing some kind of prevention work. But do they really understand what works and what does not really work? Or we just do it and, it's just a program, you do it and you finish it. So I'll talk about briefly, because I know during the course of this workshop, some people talk about in detail. In East Africa, we have such approach that the evidence has been published recently. And I can talk a little bit about the US PEPFAR GBV initiative in Tanzania, and a couple of ideas about Liverpool VCT program in Kenya. So with SASA approach, I'm sure those who own SASA will talk much better than I. But what is so striking, this is a community-based intervention, and at times it's really difficult to measure community interventions. But at least we have evidence that SASA work and work to prevent violence against women and also reduce HIV risk. And the odds are shown in there. So the question is SASA a model for East Africa when it comes to prevention work, community work? I know about some of the organizations in East Africa, like Kivulini in Mwanza, that have used SASA even before the evaluation was done. And looks like it is not evaluated, but looks like it's really promising, and the way they are progressing with the work there. So the other thing that I want to talk about is PEPFAR GBV initiative in Tanzania. And this is a framework that connects the PEPFAR GBV effort with vision to reduce HIV transmission and barriers to HIV services that I've mentioned about, either directly or indirectly. And in the PEPFAR initiative, actually, they allocated a lot of funds to program areas and supporting the government in some of the areas that they want to kind of, because then before 2011, actually, Tanzania was not really doing so much when it comes to gender-based violence intervention like Kenya or Uganda. But with this one, actually, they focused on 4 regions and support the services. There are about 20 clinical partners who are doing clinical services. I happen to lead one of the program area to integrate gender-based violence component to HIV testing and counseling services. But unfortunately, it's not that all 4 regions that are being evaluated. There's only one region that is being evaluated, and Jesse talked in the morning about the GBV Tathmini. It's a component of the framework of PEPFAR that they want to really say, with this money, with this kind of work, is it worth doing it? Can we replicate somewhere else? So apart from that, then there is a component for prevention and community protection. There are quite a number of other partners who are dealing in that area, but suffice to mention, there is a component for many involvement in the community services as well as home-based care services. And we talked about advocacy. No seems to really work from the review. But again, actually, advocacy is very part of it, and coordination from government and NGO working together to make sure that they're able to do that work. So why did I decide to talk about this one? It's a big initiative with a lot of money. And the good thing about it is it has an evaluation component, and a process evaluation is one of it, of which we can learn what are the attributes that really work and does not really work. So the other one I like to talk about is Liverpool VCT. This is one of the models I really like in East Africa. That couple, in a nutshell, couple program and operational research, and to what extent operational research informed the program, and work knowingly that we are doing something great. So then we have National AIDS Control Program of Kenya and the Fanikisha Project. That is one of the other models that talk about comprehensive care services for HIV and GBV that connect it to. And the men engaged in Kenya that mainly focus in GBV and HIV prevention. And this is a community work. So from facility as well as community work. So what are the gaps for intervention? You know, the gender inequality does not go away today or tomorrow. It's pervasive. And there's a vicious cycle of, you know, now the IPV is there and the HIV, you know, share the pool risk and keeps on going. So it's until when we really have a game changer for this element, then we can really see changes when it comes to prevention. And the other big challenge when it comes to intervention, we talk about systems well in place to really make sure that what we see as a model, good model, and, you know, scale up and be able to sustain. And the other issue is, you know, use of evidence to inform the response. So what is a common forum between those who are supposed to implement and, you know, use of evidence to make sure that whatever they do in terms of service provision or whatever they do is prevention of violence, actually they borrow from the what really worked. How efforts to address both might be improved? More evidence is needed. Maybe because of time, I just need to, I'll come back to that. But I've looked at, can you just go to the research design slide? Yes. So I have about 4 studies of which I want to share with you. But because of time, I won't really go into detail. But I'll just say, when we look at Dick and Durable study and Rachel Juke's study, actually they're kind of similar. They talk about the association between HIV and the IPV is because of physical violence attribute and not really sexual violence. And that has been echoed by Rachel Jukes as well. So it's not about women's inability to negotiate for safer sex. It's about attribute of risk by men partner because they have violent behavior. Probably, as Charlotte said, they might have other risk for HIV. So this is interesting. Can you go to the next slide, please? Next. Next, please. Yes. So I like to talk about this one because this was done in 2010 by Guy Halling et al. And published at PLOS ONE. And actually they reviewed 10 DHS data. And the data included so many countries, including Kenya and Rwanda, as a case for East Africa. And conclusion is, they said they found no association between HIV and intimate partner violence. So my question is, as Charlotte has said earlier, so what make us see the, you know, one study says there is association, the other study says there is no association. Is it because of the design? Is it because of, you know, the sampling? Is it about, what is it that makes us actually unable to really pin down and say this is it? Is it about different vulnerability? Because East Africa might be different from other regions. So, but what was so interesting here, even individual country data like Kenya and Rwanda, they showed no evidence at all. But when you look at some of these other models, like the one that was done by Jesse and Susan back in 1999, I guess, when they looked at the VCT services the IPV and HIV infection being seropositive, they found that the odds of reporting partner violence was 10 times. Can we just go? I'm kind of going very fast because of time. Yes, please. Yeah, there. Yeah. They found that the odds of reporting partner violence was 10 times higher among younger HIV positive women than young HIV negative women. So what's happening? One said the odds is 10 times, the other one says no association at all. Can you just move to the next slide? And this one in Kenya found that there was association, and this is much earlier, 2005, compared to the one that they pulled the DHS data and said there was no association. Next slide, please. So, do we have research gaps that we need to reflect and say, can we plan to design better research for us to get quality data that can inform, from different levels, from policy as well as intervention? Next slide. And the last slide, please, because of time. So what have I been saying? Research indicates that there is evidence for association between HIV and IPV. When it comes to East Africa, with few research that have pointed out, most talk about the evidence. There is evidence, and some few, there was another one that I didn't talk about, that say there is no association. And and we have models that have shown that probably we can scale up and inform policy and intervention. But by and large, my take-home message here is we need to do more research, especially in East Africa, to get context-specific issues that we need to address when it comes to intervention and policy. Thank you.